Hello, everyone. I'm Dr. Fraser, and today we're discussing a major 2025 study that offers new insight into how lifelong cholesterol levels, not just medications, may influence dementia risk. The study includes over 1 million people and uses a genetic technique called Mendelian randomization to estimate what happens when LDL and non-HDL cholesterol remain low across the entire lifespan. More specifically, it looked at genes that mimic the effects of statins, ezetimibe, and PCSK9 inhibitors. Some individuals naturally inherit genetic variants that keep their cholesterol lower from birth. These variants act on the same biological pathways as modern cholesterol-lowering therapies. For example, the HMGCR gene is a pathway targeted by statins. The MPC1L1 is a target of ezetimibe, and the PCSK9 is a target of PCSK9 inhibitors. Because these genetic differences are present from conception, they're not influenced by diet, lifestyle, or other confounders. This makes them a powerful tool for understanding the lifelong effects of cholesterol, or at least these pathways, on brain health. This large study looked at the genetic variant mimicking ezetimibe, which showed the strongest protection, a 82% lower risk of dementia. The statin-like variant also showed substantial protection at 76%. Interestingly, the PCSK9 inhibitor really was equivocal, which is interesting given that it is very potent on lowering cholesterol. Overall, the findings suggested that long-term management of non-HDL cholesterol, or more precisely, apolipoprotein B, through genetics, lifestyle, or medication, may play a meaningful role in reducing dementia risk. For those who want to read the paper directly, we'll provide the reference in the show notes.
Does this mean everyone should be on cholesterol-lowering medication to prevent dementia?
Not automatically. The study suggests that long-term lower non-HDL cholesterol, or better yet, apolipoprotein B, is associated with lower dementia risk. Alternatively, the targets of ezetimibe and statins lower dementia risk. As I noted previously, the PCSK9 inhibitors didn't show this outcome despite being substantially active at lowering ApoB. Most drug trials are short and begin late in life, making it hard to capture multi-decade benefits. The key message is that maintaining healthy cholesterol levels earlier in life may support long-term brain health, but treatment decisions remain individualized.
Why haven't medication trials shown these same dementia benefits?
So actually, there are multiple trials which have shown benefit, but not to this extent. This is primarily because of timing. Dementia-related changes begin 20 to 30 years before symptoms start. A statin or ezetimibe trial lasting only 3 to 7 years in older adults cannot capture the neurological effects that require lifelong exposure. Mendelian randomization gives us a better perspective into longer-term influences.
Ezetimibe-like genes show the strongest protection. Does that mean ezetimibe is the best option for preventing dementia?
Probably a bit premature to draw that conclusion, but I certainly have a lot of patients on both the statin and ezetimibe. In general, hitting risks through multiple pathways is a good strategy. A 2024 study indicated ezetimibe decreased risk of dementia 7-fold. Seemed too good to be true at the time, so I kind of personally dismissed that study. And now with this additional data, maybe that was correct. The genetic variant affecting NPC1L1 showed the largest effect, but genes and medications can influence pathways differently. What the study most clearly supports is pathways that impact lipids over the long term have substantial effects on dementia risk. Interestingly, ezetimibe is much less potent in its ApoB or non-HDL cholesterol lowering effect than the statins. The genetic variant affecting NPC1L1 showed the largest effect, but genes and medications can influence pathways differently. What the study most clearly supports is pathways that impact lipids over the long term have substantial effects on dementia risk. Interestingly, ezetimibe is much less potent in its ApoB or non-HDL cholesterol lowering effect than statins.
The PCSK9 related gene didn't show a clear benefit. Should I worry about PCSK9 inhibitors?
I wouldn't particularly worry about them. There's certainly nothing that's been shown that they are harmful. And the data was not completely as clear as on the other two gene variants that were looked at. But it is interesting when we have something which is very potent in regard to its cholesterol lowering impact, oftentimes more potent than statins, that didn't show the same impact. So that calls into question, is it actually lowering the ApoB that is the active issue, or is it the pathway which is the issue? And then it becomes more important to not necessarily monitor cholesterol, but to actually consider being on a statin or ezetimibe or both.
Which statin was the best and second best based on the article?
The study didn't actually compare individual statins. It examined a genetic variant in the HMGCR pathway, the same pathway that all statins target. Because this genetic effect represents mild inhibition of HMGCR from birth, it can't distinguish between drugs such as atorvastatin, rosuvastatin, or simvastatin. However, in clinical practice, if we consider which statins most closely mimic strong, consistent inhibition of this pathway, rosuvastatin is the most potent, atorvastatin is second most potent, but the other factor to consider is that atorvastatin gets across into the brain where rosuvastatin does not significantly. So I tend to favor rosuvastatin, as theoretically we want cholesterol to be high in the brain, but we want it to be low throughout the rest of the body.
Is lowering cholesterol harmful for the brain since the brain needs cholesterol?
The brain produces all of its own cholesterol behind the blood-brain barrier. Lowering blood cholesterol does not reduce the amount of cholesterol available in the brain, particularly as the two systems are actually independent. However, lipophilic statins like atorvastatin do lower cholesterol synthesis in the brain. And for this reason, I often favor using the hydrophilic statins like rosuvastatin.
If my cholesterol is already normal, does this study apply to me?
We really don't know. Was it the low ApoB or non-HDL cholesterol that had the beneficial effects? Or was it the pathways these drugs were using? We don't know the answer to that. So it is something where I would have a low threshold to consider being on a statin or ezetimibe or both as part of a longevity strategy. These findings bring compelling evidence for long-term and early use of statins and ezetimibe to support lifelong brain health. The links to the two articles discussed are in the show notes. Thank you so much for watching. Until next time, stay safe and stay healthy.